Right, so we're going to resume with debate number 2. The title is The Impossible Shared Medical Record with a question mark, with Isabelle Adnaud, Michel Gagneux, Thomas London, Hal Wolf, and the moderator will be our friend Philippe Leduc. Yes, you can certainly give them all a round of applause. After connected objects, we're going to go on to something more serious. The title is The Impossible Shared Medical Record, as we've just heard. We're going to see if it really is impossible and see if we can make it possible. Isabelle Adnaud, who's chairperson of the Pharmacists Order, for you it's a success, but you'll tell us whether it's really useful for anything. Michel Gagneux, you say, well, it's not a failure, but it's not a success either, the SMR. Thomas London, you're at McKinsey, and you're going to draw the lesson from all of this. And you're former chairman of Kaiser. You've got 10 million patients and 10 million records, Halvolf. And above all, how much did it cost? So let's have a look at the video first. The shared medical record? Well, it's rather like the story of a ship that has just been sailing round and round in the Atlantic for the past 10 years without any particular destination in mind. The project all started off by making a lot of noise in 2004 when the Minister of Health at the time, Philippe Douste-Blazy, launched the idea of a single record that would enable all the players in the health sector to know what treatments the patient had been given in the past. The idea was relevant. It looked like an effective way of improving patient management and coordination between the health professionals, avoiding, for example, superfluous examinations or dangerous drug interactions, thereby saving costly hospital care. The project seemed realistic. Hadn't Denmark launched a similar record in 1994, now used by 60% of the Danes? Thus, haloed by the shining light of all these promises, the SMR was officially launched by the law of the 13th of August 2004. It was ambitious, too ambitious perhaps. Create a record mentioning the patient's name and treatments, far too simple. The content of the SMR was to be detailed, containing the history of the patient's consultations, test results, personal risk factors, medical imaging, and even some space for the holder to make comments. Everything was there. Once tested in everyday practice with doctors who don't have time to spend hours killing information into their computers, the record began to go stale, and the SMR got a nickname, the record that never got off the ground. The ministers came and went, Xavier Bertrand, Roselyne Bachelot, Marisol Touraine. The stops and starts continued. At the end of the day, the project cost 500 million euros for 500,000 records opens, with only 10% of the information initially planned filled in. As a cruel comparison, 3 years after the SMR, the pharmaceutical record already exceeded 36 million records opened and only added up to a mere 5 million euros funded by the pharmacists themselves. The lesson to be drawn from all this: good tools are of no avail without coordination, steering, and political willpower. I can go now. We've said it all. Coordination, steering, political willpower. Isabelle Adnaud, you have the pharmaceutical record, and it seems a lot simpler than the shared medical record. Can you tell me how you succeeded? It's the pharmacist who developed it. Is that the key of its success? Yes. It's a professional tool that enables the pharmacists, whether they're in the hospitals or in the city, to do their job properly. And in only a few seconds, they'll get a record of what every patient has taken in any pharmacy and calculate the drug interactions. But what's made it so successful? There were some pharmacists who didn't want it to start with. Well, it was impossible to be rational because the pharmacists were paying for the record. It was difficult to say to them, you're going to have to pay for it to start with. So I think it was successful because we played on their emotions. The pharmacists hate to think that they're just people who supply boxes. So if you give them the way they need to do their job properly, what they've been trained for, they feel proud of it and they have a collective ambition. Did you perhaps not play on the emotions sufficiently? 500,000 medical records were created. 1 out of 2 is empty. 1 out of 4 the information is not properly filled in and perhaps not used. You launched the project into 2008, 2009. It cost 250 million for the first version, 150 million according to you, but it's not a failure for you because it does actually work. But it's just the politicians who didn't take the right decision at the right time. So why didn't it work? Beyond the problems related to the political part of the project, I think that maybe it might be interesting to take a step back and analyze the reason for which this type of project, which had a national vocation, was so difficult to deploy. But it does work. You confirm that it works. Yes, I demonstrate that regularly. About 10 days ago, I was with the Commission for Social Affairs at Senate, and I demonstrated that it worked. And why didn't it work to start with? Well, because when it was launched, we were in an ecosystem in which we were not really mature enough in this new approach, this digital approach to health. The professors of health, the representatives of the doctors were extremely circumspect about using this type of tool, and it was difficult to deploy in the hospitals because the software packages were vulnerable and not of the same standard for the health professionals. The political decision makers as well. They didn't have the capacity to carry along such a complex project, so we weren't ready. Didn't you take that into account in 2009? Well, we did. But I think that what we really needed to do was prepare the ecosystem. I think the project was something revealing of the weaknesses that we had in France in terms of modernizing our health system. But it was a necessary catalyst to create the right conditions. If there hadn't been the project, I don't think we would have moved forward as quickly on setting up the interoperability framework for our IT systems so that they could communicate together. We wouldn't have worked on getting the patient's informed consent. We wouldn't have moved forward so quickly on the security project for sharing and exchanging information. What happened in 2009? Well, I think that if I had to do it again, I'd propose the same thing. But as it was in an ecosystem that wasn't prepared, because in 2008 there was a ministerial mission that handed in a report, a very critical report on the first version of the SMR, and relaunch it on new basis, we would have made the same proposal, except that the SMR had become a symbol of a project that had risks for the people who were carrying it along. And that meant that there was a lot of hesitation. We needed to take the time so that it became mature and people saw that the SMR was really necessary. The minister has now confirmed this. Well, let's go once around the table and talk about the future before we continue. You were saying that, isn't it the ministers really, whether they're right or left, they perhaps didn't go for the deployment?
Faced with a complex environment, a minister is always responsible to take the decision or not. But I think all of this is not the most important aspect. I think it's really in everyone's collective interest, anyone interested in digital healthcare, to try to analyze the systemic reasons for the difficulties of such a project so that we don't repeat them again. You talked about connected objects this morning. There will be issues of this type. And it's you saw that it's quite a mess, all of these issues. So we need to learn from the past. So you're optimistic today? Yes. You think it will work for everyone? Yes, because today digital healthcare is, I think, reaching a first level of maturity. A digital hospital program has been launched. Telemedicine is getting off the ground. The prerequisites are in place. So you said it cost, yes, the first phase cost 90 million until 2008. As of 2009 till 2013, 90 other million euros were spent to build it and set up pilots. And today, the maintaining an operating condition and the necessary technical upgrades cost about 12 million per year. When you add it all together, that adds up to about 250 million, which is very low compared to other similar projects. Hal Wolf, you're the former SVP and COO of Kaiser Permanente. It's an integrated healthcare company. You're present in 8 states plus Washington, D.C. You're in charge of 10 million patients, 38 hospitals, 619 establishments of secondary and primary, 170,000 employees. You decided in 2001 to launch what we call the DMP in France, an electronic medical record, and it worked. Now, there are 2 things. You can tell us more how you proceeded, but it cost $4.5 billion. That's costly when we look at 5 million and 250 million euros, but it works. And the 10 million of your patients all have an electronic medical record, and doctors are salaried for you. You say if you want to use the DMP, that's the way it works, and they used it. So can you tell us a bit more about, outside of Kaiser, whether this type of record has developed elsewhere? But what are the reasons for the success of your electronic medical record?
And of the record inside Kaiser Permanente was a mutual decision that started with all of the exact reasoning that you had in 2004. And I think that it's the fundamentals of each and every country and large-scale practice that you ultimately look at quality, access, and cost, and how do I improve it? And the fundamental business inside Kaiser is, of course, taking care of 10 million people. But like in any healthcare system, you have chronic care disease management, which fundamentally consumes 80% of the cost inside the system. So 20% of the people consume 80% of the cost very consistently. And the realization was that without a vertical and clinically integrated environment of the record, there was no consistent way to treat patients across the care continuum. We had reached walls of improving access and quality without that ability to eliminate duplicate tests, to have consistency of communication from primary care to secondary care. So it was an ambitious program initially in 2001 that actually failed in its first attempt with a homegrown product, and then finally taking one off the shelf with Epic in this particular case, which
Combien ça vous a coûté?
How much did this cost, this first failure? How much would you say that cost, that first failure?
It had spent about 500 million and was not going well. So the decision was to stop and to start over. And the second part, as you mentioned, over time, and this is over 10 years, ran to $4.5 billion. Now, in the United States, we overspend on everything in healthcare. So I think if we went back and you looked at 2004 at that time, which was a huge deployment and the world's largest at the time, you could do it today potentially for half the cost that you did it then, because lessons have been learned. But nonetheless, it was a very ambitious program of every hospital, every clinic, as well as outreach to the consumer.
Alors, les raisons du succès, alors.
So, what are the reasons for success? So, there's a doctor's file and a patient's file. Is that correct? They each have their own file, and each healthcare professional has their own file within the file. You refer to it as customized.
Let me clarify it. So the leading reason I think it was successful clearly was physician leadership. The physician community looked up and said, we're in agreement with this. Now, that was at the leadership level of the physicians. As in any system, you are surrounded by brilliant people who carry the MD label, and each one thinks about how they want to proceed independently. But when the leadership of the community got together and said, we need to do this, or we will never improve the quality and never improve our cost and access without it, there was a decision that was going to be made. Very, very unique in the Kaiser environment for a decision to be made and everyone follows it. It was quite unique. So that was a key winning attribute.
Mais les médecins
But the doctors didn't have the choice. They were obliged to use the electronic medical record with you.
It was made by the physician leadership to follow this course. The physicians underneath them. So it's a very interesting environment. The physician leaders are elected. These are not people who are appointed by administration. They are elected by their individual partnerships. And so they could easily have been unelected by making this decision. So this was a decision that was made within a Congress, if you would, of the physicians. It was a tremendous amount of conversation to ensure that people were on board. And it became classic change management. You had 30% that enthusiastically endorsed it, 30% who were enthusiastically against it, and the rest who sat in the middle and wanted to see where success would go. Today, many of the leaders who were vehemently against the electronic medical record, if you tried to take it away from them today, they would fight you just as adamantly as they fought getting it before.
En dehors de Kaiser aux États-Unis, quel est le déploiement?
So in addition to Kaiser in the US, what is the deployment of this type of electronic medical record?
And in different variations. So Denmark was mentioned earlier in the video, and I'm a visiting professor at Southern Denmark University. There it is much more of a similar relationship as you've built here, which is different EMRs that are connected together. Maccabi was mentioned earlier in the first panel and debate that took place, another fully integrated model. Singapore. You see EMRs in a number of places and countries that are being built out. And there are basically two types. One particular type of vendor for everybody, which is very difficult to do. Or, as we're doing now in the United States as a whole with meaningful use, simply funding the capability, and then as you're doing, using what we would call HIE, Health Information Exchange, to connect that data so it is made available.
On finance à l'usage, quoi, c'est ça. On finance.
So it's financed through usage. Is that you finance if the people use it, basically?
The government did in the case of the United States was to fund the initial deployments. And with those deployments, though, came a responsibility to use it at certain levels, which is the program you hear called meaningful use.
Est-ce que c'est un succès en dehors de Kaiser?
Was it a success outside of your company? Is it very widely deployed?
Results for two fundamental reasons. The triangulation of what we would call people, process, and technology. Technology is the easiest part. We can all go grab an EMR off a shelf in many different ways, expensive, free. That's the easy part. The people part is the toughest, right? It's culture. And as we would all say, culture eats strategy for lunch. And then building the processes around the use of the information, that's the key. But people have to appreciate that, and they have to buy into it. But you are beginning to see the realization, and this is the most important part. Healthcare and evidence-based medicine is advancing at a lightning speed. If we go back to the 1970s, there were 300 articles a year that were produced in the trade journals. And if you were a diligent physician, you could read one every night and keep up. Today, there are over 4,000 a year of articles and evidence-based protocols that are produced. Without IT enablement, it is impossible to keep up.
Est-ce que ces dossiers...
Now, these patient files, is it the doctor's file or the patient's file or both? And you said, does it really encourage the relationship between patients and doctors without the patient having to come to the doctor's office? Does it really facilitate this communication and coordination?
In the United States, the file is actually owned by the medical facility with tremendous respect, because all patients have complete access to their file. They may not own it legally per se, but it's a very veiled difference. Everyone recognizes that it is their personal information with full access. The patient sees what is in their file that is available to them electronically, but they can go in and get a full copy at any time, which the physician is legally responsible to give them in its entirety at any time they ask for it.
But the doctor has a secret part. The doctor has a part in which the patient cannot access. There are two files. Is that correct?
It's one file, but I think what you see in all electronic records is what's called structured data, which is the data that sits in those blanks you fill in, and unstructured data, which are the notes and the commentary. That part is hard to put out electronically through an iPhone or through the web, and that's the part that a patient would go in and say, I would like to see all the written notes as well. And those are there in a transcribed basis, but they're just generally not put out because the request for that information is relatively small, and the cost of making it just always available is difficult.
Mais voilà, c'est un coût élevé pour rendre cette information.
So it costs a lot to make that information available. But if the patient asks for the information and there's a court case, for example, and they're going to say, I want that information. So how do you manage that issue in terms of a court case?
Or someone will request the file. If the patient gives permission, then the file would be given. And it's given in CD, it can be given on a thumb drive, or it can be given in paper, depending upon the request of the patient.
D'accord. Alors, Thomas Landon, avant de revenir, savoir comment va se développer le...
Thomas, before we come and take a look at how we're developing the electronic records in France, tell me, do you think what's happening in the US transposable or not? There are things that are very similar and others that are different. Well, the Kaiser system's different, but I think we can learn a lot. To leave aside the technical aspects and avoid some of the traps into which the Brits fell, for example, we need to make sure that we avoid a monolithic model. And then, of course, the other trap is adoption. If you take the Kaiser model, there are a certain number of key success factors. And when you take a look at what we've done in France, I think we can say that we've never actually given the system of the electronic records to succeed up until now. We've never given it the capacity to succeed. Well, you're attacking Mr. Gain there, aren't you? Okay, well, I withdraw what I said there then. No, the first thing is that in terms of positioning the electronic medical record, the electronic record suffered from the departure in terms of whether this was a shared file or a personal file. It's got to be useful for the patient and also for the professional. And the Kaiser example shows that very well. The professional has to see an interest in doing it and use it, see it as a tool, in fact. That's the first thing. And now let's take a look at the future. We have 20 minutes left. And for the professionals, we've worked with the professionals, but the level of medical leadership behind the Kaiser system is also something that we need to take a look at. Well, the situation is different because the doctors, employees of Kaiser, they have salaries. Yes. And the third point is focusing on the use, focusing on what the records are used for. That's another very important issue. For somebody who sees their doctor every 3 years, what is the interest of a medical record? But for a patient that's got diabetes, it's going to be an everyday tool for the doctor. And we have to take a look at how we can make it useful right away and relate it to healthcare protocols. It's a key tool. We've got to make sure that we switch from one concept to another on how we use it and give them the means. 4.5 billion. Well, apparently you still haven't spent enough, but in 2012-13, the Cour des Comptes said that if we were going to switch and deploy the system, then we would have to reduce the means we put behind it. The last point, well, is the concept of schedule, of a clear heading. And when we switched to the medical records, we set out a schedule and we said, if we don't stick to this, it's not going to be able to work. And we have about $60,000 billion per doctor that have been spent in the USA. It's something you do, you can actually save money on the dematerialization of the reimbursement forms.
Kaiser physicians are not employees. They're part of group practices that are engaged by the Kaiser Foundation. But the main point here is that the movement for payment based upon outcome versus activity is the fundamental driver. And that's the change that is beginning to happen in the United States in the way that Medicare is being financed and in systems around the world. Activities-based incentives drive activities. When you start to shift to outcomes, it begins to change the perspective tremendously.
Isabelle Hanot, donc 37 millions, mais essentiel les pharmaciens.
Isabelle, for the pharmacists, I go to the pharmacist I see in Paris, and I've never been asked for about this. Is it useful? Yes. Well, the pharmacists can't assess themselves, of course. So we've asked 6 faculties on one hand and 8 on the other to make these assessments. And in November, they're going to bring us along the results of using the pharmaceutical record in comparison to the British system, the NHS shares 6 pieces of information per minute. We have 630 shared informations per minute. Do the pharmacists really look at this information, though? Well, it's automatically it's displayed whether they like it or not, so they get it. The figures are given. But as we were saying earlier in the debate, as far as I'm concerned, at some point in time, it's better to want to do it than to be constrained to do it. The health professionals have a vocation, and they have to want to use the system. But obviously, it's beneficial to the patient as well, and that's why. And the second thing is that you mustn't make any mistake about the challenge. Otherwise, you'll just be watering the desert. And as they said in the video, the challenge is to make more money and to save more money on solidarity. That's important. But as a health professional, you want to do the job properly. Making money or saving money is important as well, but the first thing is to do your job properly. And so your idea is that you've got to promote the profession, make them proud of what they're doing. Yes, and there are other things as well, because I was the person who carried that project along, and I was becoming very unpopular because at one point in time I never stopped saying no. The pharmaceutical records were not really as high-tech as they ought to have been, and people wanted to put other things in, such as allergies and so on. But we wanted something robust for drugs. Now, in 2015, you're not going to be in charge of the project, but you're working with the health scheme on it. Well, I'm not going to give any advice in an issue that's as complex as this one, but what I think is that you've got to you've got to cut the file into sections, such as, for example, drugs and other medical examinations and so on. When the biology labs put their results in, people are going to see how useful it is, for example, but I don't think you want to make them into cathedrals from the start. Two important levers. We need to know what the records of the future are going to be like. Well, I want to take a look at how we can encourage people to use these records, how the payment system works. Under the control of how, in the case of their electronic records, a certain number of the interactions between the patient and the doctor were dematerialized, renewing prescriptions, for example, no longer necessary to have the patient present in front of the doctor. Today in France, taking into account the way that the doctors are paid, the financial aspect is going to go against that. We use volumes as an encouragement, and the physical presence of the doctor in front of the patient, and that's going to create a clear barrier to the electronic record. All of these issues are important, and we've got to try and make the system fluid. Well, if we are going to put the nomenclature and how the patients are paid in, is going to make the system even more complex. You're very optimistic about the future electronic record, Philippe, and you consider that it's going to happen. So why is it going to work now, whereas it hasn't worked up until now? Well, I think that today all of these stakeholders have understood what the real challenge of deploying this universal tool is. Earlier, Mr. Wolf said that the challenge wasn't technological, but cultural, because it's mindsets, behaviors, practices, social presentation, and organization. Using a tool for exchange is going to affect. And there can be no success in deploying this tool, even if it works partly as it does today. If a certain number of conditions are not reunited, it has to be systemically deployed. The healthcare professionals have to be convinced that it can be used. They've got to receive the results of the radiology, the lab results, and so on, hospital details, and so on. And they've also, but at the same time, you've got to find the right way to put all this in. It's complicated, but is it going to happen? Yes, it is going to happen. The first thing is to support the healthcare professionals. So in terms of the way they're paid, for example, so the use of the electronic record is an asset for them. Is that going to be all included in the parcel? Well, I'll tell you how that's going to happen after. The third thing is we've got to integrate the software providers into the DMP so that the system is ergonomic and performs for the healthcare professionals. This is something that is starting up, but it's essential because you want to get into the electronic record on your workstation and be in permanent interaction with your own software. Because I'd like to remind you that in France, the personal electronic file is not a substitute for the electronic medical file in the hospitals. There's no point in encouraging a doctor in Marseille to use the electronic record if the hospitals in Lille are putting the information out. So there's the territorial aspect that's important as well to succeed in the deployment of the electronic record. Today, I think that everybody's understood what the challenge is, but the last axis is another very, very important one. It's a long-term subject. In our country, we have more and more difficulty in carrying along these long-term projects, and we've got to be constant, whatever the accidents that happen along the way are. And I think that the conditions are there today. As you know, the draft law plans for the transfer of the electronic record to the CNAM, the Health Insurance Fund, and there are consultations underway with the state to this effect. In 2016, the healthcare fund is legally going to be able to launch the deployment of the electronic record. There are a whole series of stages, of course, to go through to do this. And without giving you away state secrets, it's true that this is going to happen, but in consultation with healthcare professionals. So I think that we're now going into a phase during which, after having been through stop-and-go periods and all sorts of problems, we're at last going to succeed in the problem. It's going to be part of a digital ecosystem that is far more complete, and of which it's only one building brick. You said that it was important to, and you're optimistic. I'd like to underscore one of the points which is important. I think we're talking about something that is a long-term project. Kaiser has 10 million insurees. And once the solution was ready, it took 6 years to implement with a clear heading. Is it the patient or the doctor who's going to adopt the system first? Well, both. There's a French specificity here. The patient has to consent to the creation of this file in which his personal data is shown and share his or her healthcare data. It's a tool that is a daily tool, which is clearly essential for the healthcare professionals because they should use this data to coordinate the care that the patient receives and see what the results of other examinations are under the control of the patient, with room for the patient, and of course, sharing with other healthcare professionals and the patient. What about the mass data? Are we going to get caught up in that issue? Who hides data? Well, when a patient goes to the doctor very often, he doesn't say everything he should. Not always. He doesn't say everything, tell the doctor everything. And I think that a file like the personal electronic record is possibly not something that is going to be a remedy for that. But it's quite normal that some patients may want some of the data of their medical past not to be accessible to all the healthcare professionals. A woman who had an abortion of a few years earlier doesn't need to give that information to her chiropodist, for example. A patient should be able to decide to mask data. That some information should not be accessible to other healthcare professionals. Okay, so we're running out of time. Yvon Merrière, who is in charge of the electronic medical file at CNAM, said last week at a conference with the ECHOs, said that the medical record should be open. This is one of the projects that we're working on right now. The Health Insurance Fund is working on that issue because the Yvon Merrière's concern is that because there have been so many delays with this project, there may be an effect if it's deployed too fast. So this is something that's only created once in a patient's life, and it might take too long for the healthcare professionals to create these if they're doing this in their everyday practice. It does actually take 57 seconds to create the file, but you've got to give the patient the form, the informed consent form, and do other operations as well. And for some players, the time that it takes to create the file is an obstacle to deploy it first time round. So we're going to have to find a way of creating the file more quickly. It's a project that is underway. I think that this is very representative of the debate that's taken place. Well, that's good. We're taking time, querying the issues at stake and so on. We ought to be talking far more about the benefits of what it's going to contribute in the future and give ourselves the means to communicate far more clearly and faster on things that do work. And I think it would be very interesting to hear from Hal on if for a given type of population we get such and such a result, and focus the debate on that. You're saying that the debate has been of no use. No, I want to understand. We know that this is going to be wonderful, as Hal explained. The big challenge today is the chronic pathologies and coordinating the healthcare. A few words from you on the importance of all that and how we can screen for disease as well, because it does enable you to screen on different themes for chronic disease. We have 6 minutes left, a minute for everybody.
First of all, it was a tremendous amount of ground covered in the commentary. Today in the world that we come from, where full deployment has taken place, Kaiser is an example, 25% of all the encounters that are taking place are now electronic, either through email, video, or phone call, rather than face-to-face encounter. And this is because the patient is driving this. No one wants to spend 3 hours to go to the doctor to ask a 30-second question. But that is the paradigm we have today. So the take-up of the electronic and digital communication is patient-driven. It wasn't the idea of the physician. It's the idea of the patient, because it's faster, it's more convenient, and it creates better access. So that is number one. Secondly, the reimbursement models, critically important.
So doctors are not paid according to an act in the United States?
Well, in some systems like ours, the answer is yes. In other systems, fee-for-service, activity-based still occurs. But that is changing in the United States because of the reimbursement from the government. And by 2020, over 50% of all health care in the U.S. will be paid for through the government. So that trend is shifting dramatically to non-activity-based and more outcome-based activity. So the patient's driving this. There's no question. Just one other point. The clinical pharmacy that you mentioned before is now fully integrated into the care continuum. So every diagnosis which is taking place is going against clinical decision support, which has been reviewed by clinical pharmacists. And sitting in the background, just as you do here, are clinical pharmacists looking at each of all the prescriptions, because the number of prescriptions per patient in chronic care disease is huge. Often in the US, you'll have up to 17 different physicians with someone who has 4 or more chronic diseases, and they could be up to 50 different prescription drugs. There is no way to adequately cover them without the clinical pharmacist.
Isabel, we've got 4 minutes left. So what about the benefits? That's what we've been talking about. What seems to you to be important? Well, what's just been said is exact. The figures, we're talking about millions of interventions. This is what we're going to be seeing in just a few weeks' time. And we've got the figures, about what's happening. People are taking a lot of medications. Now, what I would like to say in the time left is that to be ahead of things is very important for the future of the pharmaceutical file. You need to increase the vaccine cover. To begin with, we focused on medications and vaccines, so we're going to be able to be working on that. And the second area that we want to work on concerns the medication safety chain. Two terrible things are when you don't have any more medications and counterfeit medications. So we're going to be working with these systems on these two subjects. And the vaccine calendar, will it be in the pharmaceutical file? No. Because, do people follow their vaccination? When a pharmacist sees that such and such a person has had such and such a vaccine, because they cross-reference the data, they will be able to say to the person, now maybe you need to go and see your doctor because you need to go for your booster. Should we be vaccinating ourselves against the flu this year? Yes, definitely, she says. So 1 minute to conclude, please. So out of all of that, we've talked about the medical interest. We've talked about the key success factor for the EMR in France. Well, once again, the doctors focus on use for technologies. That's where the real benefit is for certain populations of patients, not all. Let's use the tools so that we focus on issues that doctors are facing, and let's know where we're going. What direction are we heading in? Now, this population, the problem is with this kind of deployment, with a tool like the EMR, it's useful for patients who are managed because they have specific diseases, conditions that have to be coordinated. My message is for patients. For 2 years, between 2012 and 2013, I was a patient myself. You were a patient. Yes, I was a patient facing coordination problems at times. And as a patient, I sometimes felt that I had to do the coordination myself, and that's not normal. Yes, thank you. So the patient is right at the center of the debate, as we've been saying. Thank you, madam. Thank you, gentlemen.